Hello, welcome to today's webinar. Just want to make sure everyone can hear me.
Yes.
Great. Perfect. We are joined today by WellTalk, presenting a webinar, Stop the Guesswork, Make Social Determinants of Health Actionable. We are joined today by speakers Phil Fierro, Senior Vice President, Analytics Reporting for WellTalk, Jody Smith, RN, MSN, ND, Director, Consumer Journey for WellTalk, who's also a former health plan administrator. Today, you will learn real-world insights from a former health plan administrator about the impact of addressing social determinants of health. You'll also learn how to determine both social and medical needs and most effective ways to address them, and also how advancements in machine learning can help you predict and support member needs to activate them in health. And without further ado, I'll let WellTalk take it away.
Great, thank you. So yes, my name is Phil Fierro from WellTalk, and for those of you that may not be all that familiar with WellTalk, we are a data-driven enterprise software as a service company that provides a consumer activation platform. And the purpose of that platform is really to enable our customers, which includes health plans, employers, health systems, health service organizations, and so forth, activate consumers primarily by targeting and connecting those consumers directly with a very personalized set of health resources. And those resources are designed to help organizations power growth and retention, improve healthcare value, and streamline the consumer experience. As previously mentioned, my name is Phil Fierro. I'm head of applied analytics at WellTalk. And really what I and my group focus on primarily is how we can leverage advanced data such as consumer data with advanced technology and analytics to not only target but personalize recommendations for consumers. And I'll let my colleague Jody introduce herself in more depth as well.
Yeah, hi everyone. My name's Jody Smith. I'm the director of the consumer journey at WellTalk, and I am a nurse practitioner and have my doctorate in nursing and served as a health plan administrator here in Colorado. And I have an intense interest of using data to go upstream and intervene upstream. And I have a keen interest in the social drivers to the health outcomes I was seeing in my patient population. And I'm so happy to be here today. Thanks for having us.
Great, thanks, Jody. So we'll get started. There's a few different concepts and slides that we're going to go through. We also have a few polls that you all can interact in, and then we will certainly have some time for questions at the end. But just to get started, you know, we all know that social determinants of health is a huge buzzword right now, and hopefully you're all here because you realize that there are some, you know, real-world implications towards addressing them. And we're very lucky here at WellTalk to have a team, including Jody, who in her former life witnessed how social determinants can impact health and vice versa kind of directly with patients. So to start, I'm going to turn it over to Jody.
Thanks, Bill. So, you know, I feel a little like I'm preaching to the choir here with you all because nobody knows better than you all do around how the social inputs and drivers affect people's health. And so you all should feel very proud that you're ahead of the curve, but what's really coming out in the nation a little slowly behind Medicaid plans is commercial payers and even Medicare coming to the realization that to not address people's social lives and socioeconomic drivers is to miss a major portion of what affects people and patients in their day-to-day lives. So and because of that, there's a humongous misalignment in investment of actually what drivers affect a person's health and the health outcomes and the cost and utilization of the care they consume with actually where the dollars flow and where investments are made. And as you all are well aware, that to impact cost and util and health outcomes, there needs to be a better alignment of investments and resources with the actual drivers affecting the health outcomes. So So, you know, I'll just share a personal story. So for the first 20 years of my career, I was heavy on the left side of this slide. I used all of the medical solutions at my disposal and in my arsenal around diagnostics and pharmaceuticals and referrals and care sites and levels of care to provide what I thought at the time was really good quality care for my patients. And it wasn't until I started doing home visits and did thousands and thousands of home visits where I was confronted, you know, pretty acutely and had a front row seat to the social inputs to what I was dealing with, what I thought was just kind of a clinical pathophysiological basis. So, you know, the answer to this is pretty self-evident, but what is most important to people's health? Is it medical or social? And the answer clearly is to address and intervene on both. So I'm just going to share a few stories of real-world patients, and I'm sure these come across your desk and in charts to you all daily. But it was when I was providing care as a nurse practitioner in people's homes and doing homebound rounding that I realized that all of the medical care I was providing and later as a health plan administrator paying for, I realized was going to fall short if I didn't get to the root cause of what was really going on in people's homes. So the first story was a gentleman I saw, and he lived in a basement apartment and had nothing to cook with but a microwave. And so he was eating a lot of prepackaged meals, frozen dinners, and he was eating out of his microwave. And it was probably the third readmission for heart failure that he got enrolled and referred to me. And so when I went to his home, I quickly identified that because when he was in the hospital, we were micro-titrating his Lasix and beta blockers and sending him referrals to cardiologists and getting echocardiograms. But it wasn't until I walked through his door that I realized he maybe needed something a little different. And I'll get to that later. The second woman was a woman I went and saw, and a major portion of my home visits was medication reconciliation. I would spend half of my time on people's medicines. And so I always was pretty forward about asking them to get out everything they took, all of their pill bottles, and anything over the counter. And it was quickly apparent that she was missing many, many, many of her medications. And through the course of my visit with her, it was revealed that she just really couldn't afford her copays. And so a light bulb moment went off with me with her around, you know, we could have helped her with her copays. Instead, I was paying, you know, 6 times the amount on hospital admissions and ED visits and referrals. The last woman I saw, she had pretty significant end-stage lung disease. And when I went into her home, it was in the winter in the Denver metro area. And she had plasticked off her entire house except for her recliner chair, which had a little TV, and it was right off this little teeny kitchenette. And she was heating her house with her oven open. And she just could not afford her electric bill and her heat bill. And it was during that visit I actually had to send her back to the hospital because she was in such poor shape. So what I had at my disposal at the time of those home visits and when I would see people in hospitals and in clinics was the left side, you know, that I had the traditional claims data, diagnostic data, procedures, referral data, utilization data. But what I didn't have at the front lines kind of ready and available to me as a provider was any of the consumer data or social data prior to me going to the home and witnessing on a you know, one-to-one basis, which isn't really scalable and it really isn't transferable without literally going in and putting eyeballs on in the home. And you know, we know at WellTalk that you all are doing so much trying to engage your membership. You're calling them, you're sending them mailers, you're texting them probably. You're probably sending, some of you are probably sending people like me to people's homes. And so you are already so aware of the challenges people face with food insecurity, housing insecurity, transportation issues, just financial basics of paying your basic their bills. And so we want to put a crack in this wall between the medical and social and really provide a unified vision of your members by wrapping consumer data into the clinical data. So the big question is how do you validate what needs exist at the individual level so that you are able to do something about that kind of proactively. So with that, I'm going to turn it over to Phil to talk about how, with the right data, it's possible to stop guessing about what's contributing to a member's health and being able to put that knowledge to good use.
All right, so we're going to go through a few different steps, but really the first step in getting social determinants to really become actionable, we have to really start by better understanding members as individuals and consumers, not just as individuals part of a larger population or even as part of a segment. So as it relates to our individual health status, we know that approximately 30% of the factors that have an impact on our everyday health and health overall status occurs in kind of two primary buckets. One is in the clinical care setting, which is really when we're a patient within the sick care system. And for most of us, we're patients, hopefully, for very small portions of our lives. And the other 20% is around genetics. And these are two things that we can't really control all of the time, whether it's episodic or certainly things around our genetic makeup. But the remaining items, which really make up the 70%, really revolve around environmental and lifestyle behavior characteristics. And this includes things like our education level, our jobs, our relationships, our financial security, and other things within our environment that we know have such a broader now impact on our health than some of the things that historically we've come to believe just fit within the clinical care setting. And we know using data isn't really a new concept, but a lot of traditional approaches that analyze data aren't really enough. And we continue to see a lot of analytics and usage of data that tend to be more reactive in nature, tend to not utilize all relevant data that we may have about individuals. And based on the previous slide, if you're using only the clinical care setting, that could be 10% of the data points about each member when really there's so much more that we could get. Utilizing models that tend to be static and don't change as population and individual behaviors change. And then more importantly, provide very maybe interesting insights, but not necessarily insights that are all that actionable.
So now is time for our first poll. So on the right-hand side of your screen, you should see the poll pop up. And we would love to hear from you on a scale from 1 to 4, 1 being not good at all and 4 meaning you're knocking it out of the park. Please rate how well you are doing in understanding members at the individual level. And we'll give you about, 20 seconds to make sure you can find it and answer it. Okay, maybe just a few more seconds if you haven't clicked. So Phil, are you able to see the results there on your?
No, not seeing them yet. I think people are still submitting.
So as that's happening, I remember I didn't have any data either proactively or at an individual level, you know, so as a health plan administrator, I was getting large population level viewpoints that wasn't aggregated or segregated down to the individual level, nor was it predictive, nor did it include the consumer or social data. So I see that they are coming in. So about a third, no answer. About, yeah, go ahead, Phil.
Yeah, no, that's it. Yeah, somewhere around a little less than half think good, and the remaining half relative, you know, is probably not good at all or okay in general. So it sounds like some folks are somewhat comfortable, not really great, but comfortable, and some certainly may feel like they need some more data and some more improvement there.
Great, thank you guys.
All right, so moving forward onto the next step. So one of the best ways to gain as much of a broader and comprehensive view of your members is by leveraging external consumer data sources. And so when we talk about data, we talk about it in a broad sense because there's not one set of data that dominates anything else. A lot of the dependencies on data really depend on what you're trying to use it for. And the value of each different data set may vary depending on how it's being utilized. So in no way do we want to ignore, obviously, the typical data sets that are available around, you know, member eligibility, claims, you know, what's in somebody's medical records. All of that information, especially from a clinical perspective, is incredibly important and certainly is predictive and supportive of future healthcare decision making. So that continues to be foundational. We know there's a lot of different consumer data out there now that allows us to get at a lot of the different environmental and lifestyle factors that are hugely beneficial when we're trying to look at how somebody's going to behave in the future. What types of things they're going to respond to, what type of programs they're likely to engage in, and what they're likely to benefit from. So those are, this is already an advancement to what, you know, some of you may already have. But there are other dimensions as well. First, you know, now that we live kind of a universe where we have a lot of different consumer engagement platforms and programs, we have a great opportunity to actually listen to consumers about what they're interested in, how they care about their health, what motivates them as an individual, because that supplemented with what they've actually done paints a huge picture. And the last piece is tracking what they've actually done. So what we call consumer actions is we're trying to drive people to actually complete something, whether it's fill a prescription or see a provider or engage in a nutrition program and those types of things. And that feedback loop, you know, we know is incredibly important as well. So once we have a much broader perspective of each individual as a consumer, we then want to put this into practice. So one of the things that we still see is a lot of organizations try to kind of fit members into a box, meaning they focus predominantly on identifying individuals that are at risk for developing diabetes or obesity or having poor nutrition and those types of things, but then tend to push everybody still into like the same very small select set of programs. But now that we live in a world in the healthcare ecosystem where we have so many different health resources, we want to be able to leverage both data and analytics to optimize the consumer journey and accomplish those health actions in a more personalized way. So a different way to think about this is around not just looking at who has what needs. That's kind of your typical risk. Who's at risk for a chronic condition, who's at risk for utilizing high-cost services or not engaging in certain programs. That is all still very important, but once we've identified that, it's one of the things that's even more important is to say, out of all the resources I could connect to each individual, how do I determine what would be the most impactable at the individual level? So for me, as an example, I may require I may be at high risk of having poor nutrition and I'm at risk of not getting my flu shot this year. If you know that a flu shot program or campaign has really no chance of getting me to actually get a flu shot, but I have a high likelihood of joining and benefiting from a nutrition program, that could be something that's more personalized to me. And so what we really want to do is make sure we're connecting people with something that they're likely to not only join, but actually have a measurable impact from. And then finally, how do we connect them to it? What is the optimal way to contact them both from a channel and a messaging perspective that's likely to get them to actually engage in a program that's likely to have an impact. And that's what allows us to drive a very highly personalized experience. So if we drill down on an individual member, we can start to bucket some of this consumer data into different categories. So we have kind of a broad set of consumer data. We certainly have clinical attributes, environmental attributes, financial, which we know is a huge driver, and then just things about each person as kind of uniquely as an individual. And by leveraging this data, we can start to get at things like, what is this individual's access to care? What is their family status? What would they respond to? Do we think they have any financial barriers towards improving their health or engaging in health resources? And in the end, we actually paint a very detailed picture of this individual using predominantly consumer data alone. We know now what their home status is: lives alone, lower education level, closer to an ER, likely to utilize an ER frequently, no social media, only receptive to phone. These are all things that we're really deriving off of a combination of data that we have built around this individual. And you can see how many of these data points typically would be things that historically you would have to actually meet this individual to get. There historically hasn't been data available to allow you to get this until you have that face-to-face interaction, similar to what Jodi mentioned earlier, in seeing patients face-to-face. Now we can actually get a more comprehensive picture of individuals, but in a much more scalable and global way, still individualized, but for much broader populations.
Yeah, so thank you, Phil. And, you know, as you all know, being in the Medicaid world and industry, you know that the consumers and patients are really juggling so much, from finances to clinical to families and relationships and communities. And so, Phil, I had a question for you, and I just was wondering what types of information should consumer data cover to get a full picture of a consumer?
Yeah, that's a great question. There's a lot of different consumer data sources available out there, some of which I've kind of listed here. There are certainly many more, and there's some similarities amongst different vendors, and then there's certainly some clear differences. Our focus has historically really been on trying to collect a very broad set of data. But really what's most important in my perspective and in my kind of findings is that quality and accuracy of that data is much more important than the size. So having a lot of different data variables certainly is valuable. However, having high levels of confidence that when you're mapping to somebody's education level, for example, it's not an assumption. It's not assuming because they live in an area that that's their level, that you actually know for that individual that is their level of education. That is incredibly important, because historically the use of consumer data, and I say historically but it's even done now, tends to be done at the geographic level, and we know even within a ZIP +4 there can be significant differences from a socioeconomic and demographic characteristic. So typically our recommendation is not so much trying to get too broad of data, but try to get data that you are confident is accurate as possible, and that will drive the highest level of impact on your analytics, for example.
Awesome. Yeah, I think that is spot on and so needed. So we're going to turn it to the audience for another poll, and you know, with Phil's overview of consumer data, we're curious, what types of data are you using to inform your members' experiences? So we'll give you a few seconds. This one you can select all that apply, so you can choose more than one data source. I was heavy on, as a health plan administrator, claims and clinical. I didn't have a lot of access as a frontline as a provider for any consumer, and very rarely the health assessment. So a few more seconds.
Yeah, one of the interesting things that we've seen with some clients recently is a lot of organizations wanting to use consumer data only to be able to identify population and individual risk and receptivity, especially for populations like ACA populations and individuals and things that come in where you won't have a any historical claims. You won't have a past profile, but you want to intervene on any type of risky behaviors that could occur prior to them happening and the costs starting to cascade. So,
yeah, it's so important to round out that picture with consumer data. It's vital, actually. Okay. We're going to wrap up this poll. Thank you. There it is. So pretty well distributed, with the least being consumer. Interesting. And 10 and other. I'm curious what the other is. All right. Phil, anything to add to that?
No, it sounds like we have a lot of opportunity here for consumers, one of the lower ones. So we'll talk kind of about the final step then. So, the final step is making sure that we can put all this into action. And we at WellTalk use this type of data to identify which resources a person needs, what they'll respond to, and how to deliver to them. And really what we're trying to do by creating a unique experience is connecting people with the right resources at the right time. And across these different categories, some of these are things that everybody needs. Like everybody in a population may need some help on sleep management and other types of things, and that is a regular thing throughout the calendar year. Other things are more seasonal, fulfilling something like a flu shot, for example. Hopefully not a lot of episodes in care, and they're not necessarily planned, but as those things happen, we want to continue to connect individuals with a program that has the highest level of relevancy to a person, but also it allows us to maintain a level of stickiness and engagement. So taking into account not just as organizations, not just taking into account what you want somebody to do for their health, but what they want to do for their health. And there's many different use cases that this falls across. So, we use this in order to drive higher engagement, but not just higher engagement, but more successful engagement. We talked before about driving growth, improving retention, driving healthcare value. This can be anything from highly clinical programs like risk adjustment and quality programs down to just the onboarding and member retention experience. All of these types of programs and resources can be personalized, and we find are highly successfully personalized when we leverage things like consumer data. And so with analytics, a lot of the questions that we can answer are, how do we impact current performance and what best fits the population? Who specifically will be receptive or impactable by the programs I have in place and who will take action? And then what's the roadmap that I put in place to be able to achieve that action? What these charts represent is an example of how we've seen consumer data significantly improve the accuracy of the predictive models that we develop. So as an organization, one of the areas that we focus on predominantly is around predictive analytics specific to healthcare decision-making and behavior. So that's that impactability receptivity piece where we're saying, if I offer each individual different types of programs, how likely are they to join it? How likely they are to complete it, have a measurable impact, and so forth. So in examples like this, especially when we look at something like case management receptivity, what somebody, even if they, no matter how much they need it, what's their actual likelihood of engaging in a program such as case management, we found that leveraging advanced consumer data versus just your traditional clinical data, a 20% improvement in predictive accuracy. And this is pretty consistent with what we see regardless of the different areas that we typically are predicting, especially when it comes to trying to predict something like somebody's likely to engage in a program. And in terms of some examples, in this particular example, on the Medicaid side, we find a lot of organizations are trying to get support with improving Medicaid recertification. And we've built many different models around identifying those that are likely to fail recertification. And we've found that a lot of the key predictors in failing recertification beyond things like past behavior are individuals' education level. They're not just their health status, but things like their home value and their financial status. And what we typically do in these types of engagements is we help organizations prioritize individuals in order to support outbound outreach. And in this particular case, using consumer data, we were able to identify people that were 3 times more likely to get a checkup within the household and actually join recertification through that process and improve their recertification rates drastically. And another example, this goes a little bit to what Jody was mentioning earlier around home health. We're finding a lot of organizations wanting to leverage more home health programs, especially for those that are not actively traveling to their providers for their annual checkups. And in this particular organization, they wanted to ensure that anybody that they offered home health to really was not likely to actually engage in an office visit directly with their provider and would actually benefit from that option. And through advanced analytics and targeting with consumer data, we were able to reach 70% of the population and get those individuals that were not likely to actively travel to an appointment, but were likely to engage in a home health appointment, improving their, reducing their missed appointment rates by 19%. So those are, just a couple examples of cases where a lot of just the consumer data and advanced analytics drive some real results and are directly impacting consumer engagement.
Awesome, Phil. Thank you. So given all this, we're going to come upon another poll around what do you all do with social determinants of health? Do you design population-level programs, get down to the individual level? Would you or do you use it to inform future strategic plans? Or you're just not sure yet? So go ahead. We'll give it about 10 seconds to answer. Okay. So while we're waiting for those results to show up, it'll be a great segue into starting to wrap up our webinar, and I'm going to speak a little bit about if as a provider or a health plan leader, I had this level of data and analysis and insight into my population and was able to drill down to the individual level, how that would have actually, that is where transformation happens, even in a predictive manner. So it looks like pretty equally distributed too. So I'm going to take 2 on those 3 patients that I told you all about previously, around the guy who was cooking his food in a microwave, and the woman who couldn't afford her medicines, and the woman who was heating her home with her kitchen stove. If I could have a do-over, and I had this kind of insight and risk prediction that included the social drivers to health and health outcomes, I would have done things a bit differently. So with the first guy, I probably could have invested $100 in medically tailored meals and had a way more robust improvement in the outcomes he and I both were seeking versus the tens of thousands of dollars in hospital readmissions for heart failure. With the lady who couldn't afford her medications, if I had information at a population level, I could help improve benefit design and have a pharmaceutical co-payment assistance program. And then down at the individual level, it would have improved her health and had better outcomes if I could have helped her pay for her medicine. So maybe she needed a social worker, maybe more than another referral to a specialist. And then with the last person, the little old lady that I had to send back to the hospital for end-stage lung disease, she would have been a great, had I known before walking in and putting, eyeballs on. I call it the second I walk through the door when you can see and smell failure, that anything I was about to do medically wasn't going to be as impactful as if I could just give them a little help on the social root causes of the health outcomes I was seeing. So I would have loved to help her had a benefit designed to pay for her Excel bill, her heating bill, versus having to send her to the emergency room. So, and the important thing about that is having that level of data insight at a population level, and to Phil's point, that you're able to get it down to the individual level, and then have it help you assign social and clinical risk predictively to be able to intervene and partner with community resources upstream. So the first takeaway I would say is that what I was just saying about being predictive in nature is that as a health plan administrator, I was constantly looking out of the rearview mirror with claims and the claims lag, and it's what heart failure admissions were last month. It was our ED util last quarter. It was always in arrears. And so what is really powerful and would have been a really powerful with my patients at both the population and individual level is if I could have been looking out of the front windshield. So traditional data was falling way, way short for me at an individual and population level, and it had huge cost and quality implications in my organization. The second one would be that being a health plan administrator, there was this pull to start programs by disease states or by line of business. And what I think this consumer data married with clinical data does is that it actually allows you to shift from a one-size-fits-all approach. I stand up a heart failure program to I stand up a program just for Medicare members or just for Medicaid members. And if you're at risk, and I've got your back. And we have a program and intervention and strategic partnerships in your community that will help you. The third is that the consumer data really allows us and allows all of us to start addressing the root causes of the clinical outcomes. Like I said, as a provider, when I would walk into a home and see and smell failure, the root cause wasn't that they, need to see another cardiologist. They need help with medically tailored meals. They need transportation to appointments. They need care to come to them and not make them come to our bricks and mortar. They maybe need palliative care, and they need a lot of social supports and resources. So I think I encourage you all to look into consumer data, use consumer data, marry it and wrap it in and tie it into your current operating and clinical data. And now we can open it up for questions.
Great. Thank you so much, Jody and Phil. We will have the remaining time to take questions, so continue to submit your questions via the chat box located in the lower right-hand corner of your screen. And let's see what we have so far. So our first question is, where does your consumer data come from?
Yeah, so I can take that. So our consumer data comes from a few different sources. There's a lot of different actually publicly available data out there. Not all of it is necessarily individualized, but there's a lot of information that allows us to get at things like environmental factors around a consumer that are known. And then there's a lot of proprietary, private sources where you can purchase a lot of this data. And I showed some of the logos on one slide earlier of some of the predominant players in the consumer data space. But as I mentioned, they all do things a little bit differently. They all kind of collect, coalesce, and provide data a little bit differently. So my recommendation is to try to ensure that you know what you want to use that data for, and that will help kind of inform some of the best sources to utilize, whether it's one or many, to meet that need.
Great. Next question, how do you know what social determinant to address first?
Yeah, that's a great question. I'm happy to take that one. You know, I think we think that all things are created equal, but I think that's the power of using data and analytics to get to the individual level and make it individualized. That I use this example a lot, that if I had two people sitting next to each other with the same exact clinical severity of, let's pick heart failure, but it could be diabetes or COPD, it could be anything. And they have the exact same clinical severity, but one person lived with a really supportive spouse, had a great community, had some finances to afford healthy foods and their copays, and the same exact clinical severity in the person sitting next to them, and they lived alone and didn't cook and are recently widowed and are suffering from depression. They need way different things. So I think food insecurity always pops to the top because it's, you know, just that kind of basic foundational part of Maslow's hierarchy, right? But I think there's some innovative things to be doing with housing security and transportation that, you know, the likes of United and even Medicare are starting to look into. But as a nurse practitioner in my community, I was wearing a path in the road to the same zip code. So there's a really clear, strong connection between socioeconomic status, as you all are very well aware. And so, you know, what does finances help with the housing security, food security, transportation issues, and even caregiving issues people are dealing with. So the point is to get individual and try to stay away a little bit from a one-size-fits-all approach.
Perfect, thank you. And then one more question, what would you say is the value of personalization for Medicaid plans in particular?
And so one example that we gave earlier was around Medicaid recertification, but I think in general, you know, as many of you probably experienced, for Medicaid members, the amount of data you have on the clinical side is often very thin, much thinner than you would like it to be. And even though oftentimes some of these members are harder to reach, that doesn't mean they don't have a broad consumer footprint. And, you know, we have been successful in being able to connect a lot of this consumer data to various Medicaid recipients, and we know that the value of getting them to engage is incredibly important. And so when we do things like trying to map out channel preference, what is the most appropriate channel to engage somebody like a Medicaid member? Is it mail? Is it phone? Is it IVR? Is it text? Whatever it might be. We have a lot of predispositions on what that might be, but actually being able to model that at an individual level and say, connect this person through this channel, this person through this other channel, we've seen some pretty significant increases in engagement through that multi-channel approach. And we found consumer data is very valuable when we're trying to do things like that.
Great, great. Phil, you don't mind going back to your screen with your contact information? I want to give everyone an opportunity to capture your information again.
Of course.
Perfect. So there you are there, everyone, if you would like to reach out to them. And Jody and Phil, if you want to share your info, I can do it here actually. If you want to reach Phil, you can reach him at phil.fiero@welltalk.com. And Jody can be reached at Jody, JODI.Smith, SMITH, @welltalk.com. Thank you all again for your time today. Thank you, WellTalk, for presenting. And we look forward to seeing you again on one of our Webinar Wednesdays. Have a great night. Thank you.